Otherwise, sideline. You guys remember from CP3 or was it CP3 for you or Stan?
Yeah.
Oh.
CP3 or okay, so the glutmed. What's the short position for the glutmed? Right. Where's the long position?
All the way across.
Right. So knee to the chest, basically. Okay. So if I want to do the glutmed assisted or active assisted, I can start here and bring it all the way up to there. Yep. And I can even have the patient bring it in too. So if I want to do actively, they can start here. I can do double thumb and they can pull it in. Okay. Sometimes just because of the weight of the patient or the strength of the patient, I don't necessarily have them do this whole move here. I just have them start from here to here rather than doing the whole abduction thing. But if they can do it, great. Okay? Glutmax. So remember the glutmed is the triangle-shaped muscle that ends at the greater trochanter here and kind of fans out to the iliac crest. So it's a pizza-shaped muscle. Okay? The glutmax is going to be on the most posterior aspect of it. Okay? It goes from the lateral border of the sacrum, okay, all the way to the IT band and the gluteal tubercle. Okay? So to get the glutmax now, I can do the same move. I just got to change my position. Okay? So I might get more of a position down here and have them do the same type of movement. Does that make sense? Okay? IT band, same thing. Start in a short position and end in a long position. Okay? I can do the proximal aspect. I can do the distal aspect. If I really want to get a stretch on it, I can do like an Auber's position and work it down here. Okay? If I can just keep it statically and really work on the stretch. A lot of times in this position too, I can get kind of the whole QL into the glutmed, into the IT band fascia by bringing the patient's arm overhead here. Okay, and I'll support him with my outside leg like this, and I can work all the way down, kind of as one big long motor unit. Okay. And that's the sideline QL would be this right here. So it's hand overhead. So I'm trying to recreate as much lateral flexion in a sideline position as I can. Make sense? Okay. Supine, lay on your back. Oh, sorry. One other way you can get at the glutes if the patient's real heavy, or actually, I don't care about the patient, if his leg's real heavy, is they can do like an elbow. Okay? So you can do active, passive, or active, and you can just dig your elbow in. Be careful not to hit the greater tuberosity because you can give them a bursitis. An iatrogenic bursitis. What does that mean, Simon?
I mean,
Doctor-induced.
Yeah, doctor induced.
Yeah,
Okay.
I know the first chapter.
Okay. Alright, let's go supine. Any questions with the sideline ones? Okay. So in this position, we're going to hit the anterior structures that affect the low back. We got the rectus femoris. We got the psoas. Okay. We can get the adductors in this position too. Dr. Horgan once told me if somebody held a gun to his head and you said you can only treat one muscle for the low back, what would it be? Psoas. Why? It's the only muscle that has direct attachments to the bodies and the discs. The only one. Okay, so it has a lot of effect on low back pain, both in facet type patients where extension is more painful, and in disc patients because it actually has that connection to the disc and it can shear the discs from an anterior direction. Okay? So like you learned in STAMP, you're just going to have them start in a shortened position here, and you're going to have them slide their heel down the table for actively. You could also do active assisted and just do that same position. Okay? I usually will dig in with my fingers here. Usually to try to find a good starting point in the psoas, I go halfway between the umbilicus and the iliac crest. Okay? That's where I'll start. Then I'll usually move up and down a little bit. Have patients put their hands on their chest here. If they put their hands on their head, why is that not helpful? Tightens it, right? Tightens the abdominal muscles. Okay? So that's with psoas. Quadriceps, I like to split two joint muscles into distal and proximal. Okay, so like the IT band, the quadriceps, the hamstrings, I like to look at it as a distal portion and a proximal portion. If I want to do the distal aspect of the quadriceps, and this is going to overlap with knee, obviously, okay, as we start here, this is going to be the short position, this is going to be the long position. So I'll work, start short, and I'll work the, I'll work the distal portion here, okay? If I want to work the proximal portion, this is going to be short, and this is going to be long, so it's going to be almost like a psoas move, okay? Except I'm going to be right on the proximal portion, okay? With the adductors, you can keep the knee straight to keep the gracilis in it. You can bend the knee to take the gracilis out. I usually just put it in either a lengthened position this way and work that way, okay? Or I can start short, go to long, okay? My position with the proximal rectus, the proximal adductors, all that stuff, is just be honest with your patient, okay? You're going to say, I feel a tear, and you're having pain right at the insertion against the bone. Okay, that muscle, and I'll pull out a muscle chart and say that muscle goes all the way up and attaches to the top of the pelvis. That's where I feel the lesion. And in my exam, I'm upfront with them too. I'm going to follow this muscle straight to the bone. And I'm just go there, and I'm going to follow this muscle and palpate it all the way up to the bone. Is this tender? Is this tender? Is this tender? Okay? Keep your eyes on the patient's eyes or at a different spot in the room. Don't look down. Okay? It's subtle, but it makes a difference. Okay? If I'm working on a female and I'm looking at my contact the whole time, that's not a good comforting look for a doctor to have on their face, right? So I'll look at them straight in the eye as I talk to them, or I'm looking somewhere else in the room. Okay? And I usually have a towel. Just have a towel through here too. Okay? But you know, you got to be honest with them too. I had one of the St. Paul athletes one time. He had a groin tear, and I said, "Look, buddy, you pulled your groin, and it's right up here, and I'm going to work on it, and that's what's going to get you better." And he's like, "Are you serious?" And I'm like, "Hey, I don't want to do this any more than you want to do this. But if you want to play Friday night, we got to get this done. Okay, let's do this dance." Okay.
I did not put the muscle there.
All right, and for the proximal hamstrings, any idea how we can get at the proximal hamstring? Yeah, just like this, right? So in this supine position, we can have him flex his leg up and we can get a length into the proximal hamstrings, okay? So I usually have... Okay, so I'll put the a towel right here, okay? And I'll usually put a towel over their shoe or their foot, whatever, and I'll put it right up against my shoulder, and I'll get in and work the hamstring down, okay? Or I can do it actively. So I come in here, my fingers are on the outside, not the inside, okay? And I can work it down as they pull it up, okay? So I'm trying to get the proximal aspect of the hamstring. And this one sucks. This hurts bad. Okay, so I really lighten up on my pressure on this one. The posterior aspect of the adductors in this one and the proximal aspect of the hamstrings, and you're also hitting part of the glute, that's really tender. So just lay off on your pressure. Because again, I don't want to do soft tissue on a muscle that's contracting. Okay? Everything else on there?